Hello, everybody. Everybody here? I hear somebody. How you doing? It's okay. You don't have to talk. Okay, we start in about 40 minutes, okay? But you got your seat. Okay.
Welcome, everybody. Some people had questions. You want to ask me questions? A couple people had their hand raised. We start in 25 minutes. Testing 1, 2.
Testing 1, 2. Welcome, everybody. We start in about 15 minutes. Trung, how you doing? From Vietnam. Welcome, everybody. We start in about 15 minutes. Trung, can you see me? Trung, how you doing? From Vietnam. Why is it still here?
Hi, John. How are you? Hi, John. How are you?
Hi, how you doing?
Yeah.
You don't have a camera today?
Yeah.
How you
Long
been?
time
How
no
are
see.
things? How are things in Vietnam?
Yeah, it's good. It's a normal day.
Oh, it's been.
The pandemic is over. Now we
Good for you. It's better there, huh?
yeah, we change the strategy. Now we accept the COVID-19 as a part of life.
Oh, okay. Good morning, Ben.
Good morning, John.
How are you
Good
today?
morning, Dr. Bin.
Hi.
Hi.
This is Trent's from Vietnam. He's from Vietnam.
Ah, great.
We know together.
Yeah.
Yeah, Vietnam has a very active community in neurosurgery.
Yes.
But
I visited Hanoi twice.
Yes.
Yeah.
yeah, it looks like a real nice place. You know, Ben, I got nervous. I didn't hear from you, huh? I don't know.
I think he's preparing the Shaolin conference. It's a very big conference every
Very
year.
big.
Yeah,
Okay.
at November.
Oh, okay.
Yeah.
Is it in Beijing?
No, Zhengzhou
Oh, okay. Different city.
in his hospital. Yeah, and
In his hospital?
yes,
Oh,
they are the
wow.
host. Yeah.
Oh, wow. Yeah, there's a lot of work
Yes.
to do.
The first Shaolin conference actually, there's around 3,000 attendees.
Oh my God. Well, you know, is it in English or Chinese?
In Chinese, mostly in
okay.
Chinese. Yeah.
Because we'd like to televise that if we could.
Mm-hmm.
We can televise it in Chinese too. So I'll try to talk to him about that. Good morning, Dr. Lanzino.
Good morning.
How
Good
are
morning.
you?
Good morning.
Good morning.
Good
Professor
morning.
Lanzino.
Of course, you know, Ben.
How are you? It's already cold in Rochester.
It's already cold.
Okay.
Well, Rochester is colder than most of the country, I think. I think
Yeah.
Minnesota is one of the coldest states, right, Giuseppe?
Yeah. And you know, like it's funny, like sometimes we have temperatures that are even colder than the North Pole.
Really?
I check some days and we are
Okay.
but
Yeah.
it's not that bad. It's actually a pretty good place to live.
Do you have to plug your car in at night? Do you know what I mean?
Yeah. We have heated garages.
Oh, okay.
Yeah. And the other thing is that the downtown areas in Minnesota, big cities, they are all connected either by skyways. Basically, there are covered with glass bridges between buildings. Or in Rochester, we have what's called the subways, basically a connection between among most of the hotels downtown, the Mayo Clinic offices, and some of the buildings around the Mayo Clinic. So especially for patients, they don't have to go outside to go to their appointments.
It's convenient for doctors too. They can
Yeah,
do the rounds and just leave on the lab coat. You just walk around in the lab coat.
Yeah, and then, you know, like it's lunchtime, it's actually a pretty busy area. There are some restaurants, and so.
Well, you know, the question I have is, where can you get good pasta in Rochester?
Well, we're working on that.
Well, I'm sure it's not like Italy.
Let me quickly, I'll share the screen and make sure that everything goes, sure. It's going here, the videos, there are some videos.
Do you have audio in the video at all?
Yeah, this is a video, you see it?
Yeah, see, perfect. But you don't have audio, right?
No, there is no audio. Then
okay,
this is, This is another one.
It's free. Oh, there it is. Okay.
So, Dr. Shubin, we have prepared 5 cases, and some it's like to facilitate discussion. So the first case, it's what to do with an aneurysm associated with an AVM, and also we can discuss the treatment of this patient with the ruptured AVM. The second case, we did a webinar yesterday, and we presented the case of a pontomesencephalic cavernous malformation that was treated through a posterior interpalatal transtentorial approach, and everybody was really interested. Actually, there is a video from your team in I think it was published in Operative Neurosurgery of very similar case. So I thought there was a lot of discussion, and so I thought it was good to again talk about the case, and then we have another very similar one. And then the fourth case is this one. It's a ruptured cavernous malformation, parasagittal. And here we did a contralateral transfalcine approach. So we can discuss about that. And the last case is a spinal dural AV fistula that we can discuss some of the pitfalls and treatment, and then so these are the 5 cases that we have for today.
Okay.
Then I want to talk to you. I have 3 cases of moya moya with the dural fistulas. Have you seen that in the same patient?
I only see 2 cases.
Yeah.
Moya moya. Maybe because I think it's a kind of spontaneous angiogenesis.
Yeah,
But
I agree.
maybe there's some mistake. So
Right.
misrecognize
Right.
the artery to the vein. So
yeah.
So then form the DAVF. Yeah. Yes, sometimes it's happened, but my 2 cases is all good. No problem. No symptoms. Only followed up DSA find that.
Yeah.
So how about your 3 cases?
These were found even before any treatment.
Okay.
So but I think it's the same mechanism.
Already have some spontaneous stomas?
One of them, yes. The other 2,
okay.
no.
Okay.
Yeah. So I thought it was interesting.
So it's a type 1.
The
Type 1
fistulas,
or type 3? Type 2, type 3.
they were all, one was type 2, the other 2 were type 3.
Okay.
Takashi's on his way in. Now, what area of Italy you're from, Giuseppe?
I'm from southern part, Calabria.
They tell me that all the regions are different. The food is different. You can go from one region to another. It's different.
Yeah, I mean the food and the wine actually, and the dialect they actually change from small town to small town within a few miles. It's
Really?
yeah, it's funny.
Can't understand basic Italian though.
Yeah, now it was more in the past, but now with with TV and all the connections, everybody speaks good Italian. But even when I was growing up, it was very common in the villages that people would speak dialect, and every little town there are different minor changes within the same regions, but it's different.
So southern Italy, are you close to Sicily?
Yeah, right. It's Calabria, so it's the last region before you cross the Messina Strait
That's
to
Messina,
get to Sicily.
from Greek mythology.
We should organize a Neurosurgical TV live broadcast from
I would
from
love
Italy.
to. I would love to do that. I would love to tour. I love to do shows all around Italy, go from one city to the next.
Mhm.
Good morning, Nick. Are
Hey,
you
good
there,
morning,
Nick?
Don. I'm here. How you doing?
Good. So I'll just turn it over to you, Nick, okay? I'll just introduce you and then you can introduce Dr. Lanzino, okay?
Sure. Yep, sounds good.
And then you take it from there.
Excellent.
We televised Dr. Sufianov last night from Russia.
Uh-huh. Oh wow.
I don't know if you met, have you met Dr. Sufianov?
No.
No, okay. Yeah, he pretty well stays in his part of, seems to stay in his part of the world. But he's not experimenting because he's done this before. But I think he's going to start to do it more.
Where in Russia?
He's in Tyumen, which is actually called Siberia. It's southern Siberia. It sounds pretty desolate, but it's not. Tyumen's a good sized city in southern Siberia. Of course, Burdenko is a big one, I guess, in Moscow.
Yeah. I was reading while I was in Italy in August. I was reading that this year they had trouble with fires, even in Siberia.
Really?
Yeah, in the summer.
Excuse me, Nick, you're a resident, right? Or
Nick
fellow?
is our fellow. Yeah.
Fellow, okay.
It's near enough, John. I've been called worse before, so.
Good morning, Takashi.
Good evening. Good evening.
Good evening in Japan.
Good evening. Now 8 p.m. In Tokyo, Japan. Good evening, Dr. Lanzino. I'm very good to see you.
Good evening.
Welcome.
Thank you for helping us out with the Japanese colleagues.
Yes, I'm eager to join. And for Japanese fellows, so I will help to transfer English to Japanese. Thank you.
Okay. Roshan. Okay, Nick and Dr. Lanzino, here we go. 10, 9, 8, 7, 6, 5, 4, 3. Good morning, it's Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have today Giuseppe Lanzino from the Mayo Clinic. He's back. He's restarting his series, and I'll turn it over to Nicholas Borg. He's a fellow working with Dr. Lanzino. Welcome, Nick.
Thanks, Mr. Bennett, and good morning, afternoon, and evening, everybody. Thanks for joining us. I see a lot of familiar faces here, so many of you will know Dr. Lanzino, but if you haven't met him before, he's a Mayo-based hybrid endovascular surgeon, one of the most academically and clinically accomplished surgeons in this country and possibly the world. But without further ado, I'll pass the microphone to Dr. Lanzino. Actually, before we start, I just wanted to say something about the chat. So we want to try to make this as interactive as possible. I'll try to moderate questions through the chat. So as Dr. Lanzino is talking, if you have any questions, please put them in the chat. And then whenever we come to a natural break, I'll put the questions to Dr. Lanzino. If you have access to a camera and the microphone and you want to ask the questions yourselves, it's really nice to see people's faces and hear their voices. And with that, I'll hand over to Dr. Lanzino.
Thank you, Nick. Thanks, John, for helping us with this. And as Nick mentioned, what we like to do is we have prepared a few cases. Some are fairly simple and straightforward cases, but each case has an angle where hopefully we can have some discussion. And as we know, the purpose of this series is to discuss in a hopefully very interactive fashion, different, mostly neurovascular cases. And also we'll present some unusual cases. And the hope there is that as we found unusual cases, we can stimulate other colleagues that have seen similar cases so that we can learn more together. So the first case is brings home the concept of what to do with an aneurysm that is associated with an AVM. And this presentation, I'm indebted to one of our residents, Jennifer Perez, and our fellow Eduardo Agosti. So this is the patient. This is the case of the patient. So he's a 62-year-old man who presented to the emergency department in an outside institution. And this main complaint was blurry vision. That's how he defined, and that's how the patient perceived the deficit that had come up, but was not going away. So he had noticed something was not right with this vision. And this is the CT scan, and you can see that he has a hemorrhage in the left parietal occipital area. There are some calcifications, and then you can see that inside the hemorrhage, there is a mass, and the combination, of course, points to a arteriovenous malformation. So again, this is a 62-year-old man who presents with ruptured arteriovenous malformation and visual symptoms. Here is the MRI with contrast, and you can see the typical appearance of the arteriovenous malformation. There is a large varix, and you can see also that there is an aneurysm in the fairly large aneurysm in the anterior communicating artery region. And not very well seen on this MRI, there is also an aneurysm, a small aneurysm at the middle cerebral artery bifurcation. And that will be actually very important in this specific case, and we'll go on and discuss. So he has an established visual field defect, and this is the result of the automated perimetry. Here is the angiogram. So here's the large anterior communicating artery aneurysm. And this is the vertebral injection. So large feeders from posterior cerebral artery, and you can see a venous drainage with the recruitment of multiple veins, indicating possible venous outflow obstruction at some point, as also suggested by the presence of these large venous varix. And here we see the supply also from parietal, temporoparietal branches of the middle cerebral artery. And you don't see very well in this picture on the AP, but you can get a hint that at the MCA bifurcation, there is also a small aneurysm. We'll talk about that. So we have a ruptured AVM that is associated with intracranial aneurysms. These aneurysms are one very large at the anterior communicating artery area. The other one is on the middle cerebral artery. You can see here that you don't see the anterior cerebral artery on the AP from the left, but that's not because there is no anterior cerebral arteries, but because you can see that there is still from the other side, and you can see that the left anterior cerebral artery territory is supplied by the contralateral A1, and we'll see that, as I said, that there is an A1 on this side, but it's just overwhelmed by the supply to the AVM. So the two aneurysms are flow-related aneurysms. They form because of the coexistence of the AVM, but they are remote in relation to the AVM, and the AVM is what has ruptured. So I think we can pause here, and we can discuss here what are our options in terms of treatment. So the AVM has ruptured. The patient has a established visual field defect that goes along with the site of the AVM and the site of the rupture. And then we have the complicating issue, particularly of this anterior communicating artery aneurysm that is very large. So I think we are in agreement that at least the anterior, the AVM should be should be treated. It's accessible. The patient has already a fixed deficit that corresponds to the area of the AVM. And of course, the AVM is ruptured, and there are, from the hemodynamics, you can suspect that there is an area of venous outflow, relative obstruction with formation of a fairly large venous varix. And then we have this flow-related anterior communicating artery aneurysm that is not ruptured, but it's a large one. And the other issue of the small aneurysm. So this patient came to us after already had some treatment. So I don't know if anybody from the audience panelists would like to add anything. Nick, do we have any comment in the chat or?
No comments
Giuseppe,
yet. The chat's
Giuseppe,
open.
can I
Professor
make a
Goel,
comment?
please,
Yeah,
please.
yeah. Giuseppe, now you know what, Giuseppe, this is one thing is flow-related aneurysms suggest that this AVM is a very high flow AVM because flow-related aneurysms will develop only in high flow AVM. So this gives a signal that we are going to deal with a little bit of a difficult surgical issue. That is number one. Second thing is, you know what, this AVM is fed essentially by PCA. And the aneurysms that we see are not in the PCA, they are in the anterior communicating and in the middle cerebral artery territory. So this is a very unusual location for flow-related aneurysms because flow-related aneurysm, if at all they would have occurred, they would have occurred in PCA where there is no actual flow-related aneurysm. So I'm not even sure that whether we are dealing, whether these are actually flow-related or they are not flow-related, because usually flow-related will come in the feeding vessel. The third thing is, and that is the main issue that you would like to discuss and you are probably discussing, that the issue is about the treatment of AVM. And once you remove the AVM, the flow goes and the aneurysm spontaneously disappears. That is my concept and that is my belief on the basis of a number of cases. So now I would like to have your opinion on both these issues, whether we are actually having a flow-related aneurysm and how you are going to treat them. Giuseppe.
Yes, excellent points. And actually you anticipated some of the things that we will discuss with some of the slides. But going to your to the issue of the aneurysms, as we'll see, about 20% of arteriovenous malformations have aneurysms associated with them. And we are talking about true berry aneurysms. Now, some are unrelated. For example, if this patient would have had a contralateral MC aneurysm, that would have been unrelated to the AVM. The flow-related aneurysms, you are correct that there are distal flow-related aneurysms that are along a feeding pedicle, and then there are some there are some proximal flow-related aneurysms that tend to occur at sites where normally we see aneurysms. So in this case, that anterior communicating artery was under increased stress because the flow had rerouted. As a matter of fact, after we treat the AVM, you will see that there is an anterior cerebral artery on the left side that we can see. And also that small, the small MCA aneurysm was a proximal flow-related aneurysm, and you will see that the point of this presentation is as that aneurysm actually, as you said, will regress. So this is what this patient was done. As I said, that this patient came to us after this treatment, and so they coiled the anterior communicating artery aneurysm. Was a simple coiling. And I think that we can discuss whether or not this aneurysm needed to be treated before the AVMs. But what they did here that was very smart is that once they decided to treat this aneurysm, they treated with the coils only. So you can see that there is a small residual neck. But by treating these aneurysms this way without stent assisted, then the patient does not require any antiplatelet medications. And what they did, they also did the partial embolization of the AVM, primarily addressing the PCA feeders. that so you can see that there is decreased flow, decreased filling from the PCA. Now, the treatment of this AVM, I would say that, of course, we can, nowadays, this could potentially be treated with embolization alone. It's not something that I would have personally even consider, because I think that trying to cure this AVM with embolization, at least in my hands, carries a risk that is higher than some of the other alternatives. Then we have radiosurgery. In this case, the AVM is ruptured. So while we wait for the radiosurgery to take place, of course, the patient is exposed to the risk of bleeding in the latency phase. The other issue in this patient is 62. And what we have seen in our experience with the radiosurgery, that the response to radiosurgery, so this patient would not qualify because it's ruptured and you have other good alternatives for treatment, for cure. And also the age is older age, and the patients in this age group don't respond to radiosurgery as well as some of the much younger patients that we have seen. So in our institution, these AVMs would be considered for surgery, and then with or without a pre-surgical endovascular embolization. I would say that most of the feeders to this AVM are accessible. So the embolization, yes, it's nice. In this case, it decreased the flow to the AVM, makes the surgery a little bit easier. It also helps to map in a way some of the feeders to the AVM, so you don't have to spend too much time to try to understand if a vessel is going to the AVM, it's en passage or not, because they are already mapped and plugged by the embolic material.
Giuseppe, before you go further, can I ask you one more question?
Sure.
Question is, you see this patient has complete hemianopia. I want to ask you whether this hemianopia developed after embolization or was it present before the treatment had been started? This is very important for me to know, because complete hemianopia that this patient has is an absolutely unusual finding in this size AVM. My feeling is there may be some field defect here and there. My feeling is that this patient might have developed this hemianopia following embolization. What is your, can you clarify this issue?
Yeah, the patient presented originally with what he perceived as a blurry vision. So he presented with visual symptoms, and also had a sizable hemorrhage. So again, I don't, it came to me after the embolization, and we did the perimetry. This was already 2-3 weeks into his clinical course. So I cannot answer the question, how much of this could have been related to the embolization, how much could have been related. Of course, it was, I agree with you, it's not to the AVM per se, because it's close to the, but most likely was related, I think, a combination of AVM plus the acute hemorrhage.
Not embolization cannot cause this, you think?
Oh no, it can, of course, embolization might have caused it, but in this specific case, I don't know, because I saw him only after he had that partial embolization. But he presented with hemorrhage. He did present with visual symptoms. So because of the location, the hemorrhage, and the presentation, I suspect that he did have some. I'm not sure if it was that dense. Could have definitely been aggravated by embolization of posterior cerebral artery feeders.
Okay, okay, thank you.
So here is, we decided to go ahead with the surgical treatment of this AVM. You can see this is the post-surgical treatment, the internal carotid artery injection, and then the vertebral artery injection. These studies were done the day after after surgery. And you can see that after surgery, this is a few months later, patient still a visual field cut to which he has accommodated. This is the part of that is of interest. He was very worried about that middle cerebral artery annulus that was still there. This on the left, you see the original selective left internal carotid artery injection. You see the bilobed aneurysm. You see the large inferior branch that is going to the AVM. And this is a 3D reconstruction 10 months later. You see that the inferior branch as on the right side, you see the 3D reconstruction. You see that the inferior branch has remodeled. It's much more decreased in size because it was mostly feeding to the AVM. And you can see that the aneurysm now, as Professor Goel correctly anticipated, the aneurysm has regressed. So we did this angiogram the day before potential MCA treatment, 10 months after removing the AVM, but then no treatment of the aneurysm was deemed necessary because of this spontaneous regression related to the decreased flow demand and the involution of this branch, and therefore the decreased hemodynamic stress. Once again, suggesting that despite this aneurysm being away from the nidus, was indeed a flow-related aneurysm. And again, this
Lanzino,
was the, yes.
I have a question, if you don't mind. Sorry for
Go ahead.
interrupting. So clearly the vessels sort of grow and remodel, and the size of a vessel is related to the demands of the region that it's supplying, which this vessel has demonstrated beautifully. So we assume, therefore, that this large vessel that is now no longer there only grew because of the aneurysm. Do you think when this happens, that is a pre-existing tiny vessel that grows, or is it de novo formation of a new vessel that wasn't there before?
No, it's the the vessels. The vessels are and were there, but it's the flow demand that dictates the size of the vessel. And for example, flow-related changes are well known to occur in the posterior communicating artery in patients that have carotid or vertebrobasilar occlusions. And over time, you can see how a small posterior communicating artery can increase in caliber in response to a flow demand, or vice versa. The vessel can over time regress, and you can see that, I mean, this is a nice a demonstration, because we were able to do a follow-up 10 months after treatment of the AVM. and you can see that not only the aneurysm but also the vessel has decreased in size in response to the dramatic drop in flow demand associated with treatment of the AVM. So the vessel usually are there but they respond to accordingly to flow demand. It's much more visible in AVMs. It's more not so consistent in patients with atherosclerosis.
Great, thank you.
So this brings us to the issue of flow aneurysms associated with the AVMs, and topic that we have been interested over the years. And so you can see that the flow-related aneurysms can be distal, so along the feeder to the AVM. And when they are distal, often they might be sidewall aneurysms, not necessarily in relation to a bifurcation point. Then, as we saw in this case, you can have proximal flow-related aneurysms. Those proximal flow-related aneurysms tend to be at sites where berry aneurysms normally occur, sites that are somehow associated with the flow to the AVM, as we saw in these patients, middle cerebral artery, and to less extent anterior communicating artery. Then these flow-related aneurysms are a different issue and must be distinguished from dilatation of the venous drainage. Those are more properly called venous varices, because the term aneurysm should be only for those dilatations of the vessel wall which might have alteration of the internal elastic membrane, but they maintain the composition of the normal arterial wall. Flow-related aneurysms in AVMs must also be distinguished from intranidal aneurysm. The intranidal aneurysm, it's an area of weakness along in the nidus that could be mostly on the arterial or quite often on the proximal venous side, and that's something that often indicates the site of rupture in a ruptured AVM, and again it's a different issue. Another different issue are pseudoaneurysms that might be found along perforating vessels supplying the AVM. These are usually noted at the time and they are the source of rupture when they are found because they indicate the actual rupture of a small perforating vessel because of the increased hemodynamic stress related to the flow demand as these perforating vessels can feed in AVM. Now, when we talk about aneurysms associated with AVMs, when there is a correlation and they are along pathways feeding the AVM, of course, they are related to hemodynamic factors. And it's recently what has been brought to our attention is that, there's always the issue of natural history, difficult to study for all the reasons that we know. But there is a nice article from the Pittsburgh group that showed that if you decide to consider stereotactic radiosurgery. The presence of associated aneurysms might expose that patient to an increased risk of bleeding in the latency phase as we wait for the radiosurgery to work. And therefore, the recommendation is that if you treat an AVM with radiosurgery, especially if there are important associated aneurysms, those aneurysms need to be addressed to reduce the risk of bleeding in that patient during the latency period. Now, if you treat the AVM with the surgery and the aneurysm, like in this case, the middle cerebral artery, it's not necessarily within the same field of the arteriovenous malformation, then you don't really need to treat that aneurysm right away, because many of these aneurysms can regress over time. So the treatment of an aneurysm associated with the AVM depends on the rupture status. Of course, if the aneurysm is the site of rupture, well, then you need to treat like any ruptured aneurysm. But if the aneurysm is unruptured, then treatment is recommended if the AVM is treated with radiosurgery. But if the AVM is treated with surgery and the aneurysm is not immediately available in the area of the AVM, then a wait and see strategy is reasonable, unless the aneurysm is large, like the anterior communicating artery aneurysm that we saw in this patient. Federico Cagnazzo, one of our former fellows, did the meta-analysis of the literature and confirmed that about 20% of brain AVMs have associated arterial aneurysms. And the classical association, which is very common for AVMs fed by the posterior inferior cerebellar artery, those AVMs have probably a higher incidence of associated aneurysm along that feeding pike. And more likely that these aneurysms tend to be proximal, and then about 50% of the aneurysm might be distal along the actual feeding vessel, and they might not be related, as we mentioned before, to actually a bifurcation point. And actually the distant associated aneurysms are the ones that more likely than not tend to regress over time after treatment of the AVM. In absolute terms, the most frequent location is the middle cerebral artery, followed by the anterior communicating anterior cerebral artery, which again confirm what we saw in the case that we presented. I don't know if there is any additional comment, Professor Goel.
Yeah, I want to make a smallish comment. I want to have your opinion about intranidal aneurysms and how your strategy to deal with intranidal aneurysm changes when you are treating with surgery and with embolization. How do you deal with these intranidal, whether they are arterial, whether they are venous? What is your strategy, Giuseppe?
Yeah, so the true intranidal aneurysms, if a patient comes with a complex ruptured AVM, and we can identify the feeder bearing the intranidal aneurysm that usually in these cases is the site of rupture, then we might do selective embolization of that feeder to take care of the intranidal aneurysm and in theory, decrease in that patient with the complex AVM the risk of short-term bleeding. If the AVM is treated with surgery and there is an intranidal aneurysm, then that doesn't really change the strategy. I would still follow the, classical steps in the resection of the arteriovenous malformation. Now, the treatment of venous varices, that's if you have a varus, a dilatation of the vein along the main draining vein, then you don't need to chase that varix, because it will regress over time. So there are some of these AVMs that are associated with very large venous varices. And once the AVM, you follow the surgical strategy, you disconnect the AVM and then you disconnect the proximal portion of the main draining vein. Then there is no need to chase those varices, because they tend to thrombose and regress over time.
So Giuseppe, my strategy while dealing with intranidal aneurysm is that if you can operate, of course, that is the best option, and there is no question that surgery and surgery alone is the best option for AVMs. And if you can, the question is whether you can do it or you cannot do it. That is the only question. Regarding intranidal aneurysms, suppose there is a situation where I am saying that it is too risky for me to operate, or it is not possible for me to operate, or it may lead to disastrous consequences if I operate. So in those situations, I target intranidal aneurysms by embolization. And, those are, as you mentioned, they are the weak points in the AVM. And if we can target and attack at least those, rather than, that may be the target point. What is your opinion on this for embolization, in case you are not able to operate or not having any other possibility of other treatment?
No, I think, in those situations, in the acute phase, targeted embolization is a very reasonable strategy. Now, we think that by eliminating the feeder that is, or that area of the AVM where the intranidal aneurysm is located, we might decrease the risk of bleeding over the short term. Is that true? We don't really know, but I agree with your strategy, and that would be our strategy as well.
Okay, thank you.
Prof. Lanzino?
Giuseppe, yeah.
Oh.
Okay, Giuseppe.
Okay. Yes, sir.
You are talking about the demand of the blood flow, but the demand isn't. I don't think demand is a very scientific term, because I think for the AVM feeders, the delta P is quite high before you embolize the nidus, and after you remove the nidus or embolize the nidus, actually the delta P was decreased a lot, and the energy loss in the feeders decreased a lot. So that's the cause of the regression of the aneurysm.
It's because you say because the AVM, it's a low pressure shunt, so it basically
Yes.
sucking blood from anywhere.
Yes,
it's like a fistula, sucks blood to anywhere it can. Yeah.
Yes, because of the Bernoulli's principle, the energy loss of the feeders decreased a lot. So that's the cause of the regression of the aneurysm.
Regression.
Yeah.
That's a really interesting concept, and I've got a question about that, because I've thought about it as well. So on one hand, we have the AVM, which has essentially, it's reducing the pressure downstream to the aneurysm, right, by sucking in blood. And so, like you say, the pressure differential across the aneurysm is going to be high before treatment, and then it's going to reduce after treatment. But isn't there also an argument that when you remove the AVM, the pressure in the feeding vessels actually goes up? So although the pressure differential goes down, the actual pressure goes up.
Yes, but you know, the speed, the velocity of the blood flow is decreased a lot. So the local energy loss in the aneurysm dome is decreased a lot. So actually, some researchers, they calculated the local energy loss of the aneurysm. Actually, after you remove the nidus or embolize the nidus, the local energy loss in the dome decreased.
And so there, the suggestion is
although
that,
the pressure is high,
right,
a little bit higher, yes.
So the main issue is not the intraluminal pressure, it's the pressure differential, and I guess as a surrogate for that flow, right?
Yeah, the mainly because of the velocity of the blood flow was decreased a lot.
That's great, thank you.
The other thing,
Yes.
Giuseppe, other thing I would like, because the issue is of feeding vessel aneurysm. Now, many a times I see that it is called feeding vessel aneurysm. The thing is the entire vessel that is feeding the thing, feeding the AVM, not of course in this case of yours where the aneurysm was actually in the ACOM and MCA. But if it is in the feeding vessel aneurysm, the whole vessel along with the aneurysm is actually a part of AVM. What is your view on that? Not in this case, but in general.
Yeah, no, there are some, as you said, that when you see flow-related aneurysms, suggest that the AVM is a high flow AVM. And in those cases, yes, some of the feeders are highly dysplastic, and they tend to be very tortuous, but also, you know, there might not be aneurysms, but you might see small bumps along the vessels. And the interesting things about this distal flow-related aneurysm is that they are often not associated with any bifurcation point. So they are true areas of weaknesses related to flow dynamics. Dr. Agosti,
yes,
comment,
Professor Lanzino, I have a question for you, please. We saw the meta-analysis of Cagnazzo that demonstrate the high risk of rupture of flow-related and proximal AVM aneurysm with respect to non-flow-related or distal AVM aneurysm. So in this case, so in case of flow-related and proximal AVM aneurysm, are there some other factors that you are used to consider for the early treatment of these aneurysms, such as morphology of the aneurysm, location of the aneurysm, compared to a wait-and-see strategy? Or is there any extra attention that is paid in terms of reduction of follow-up timing in case of aneurysm are not so near the nidus of AVM and therefore not treatable directly during AVM surgery? Thanks.
Yeah, so if we see that there is a more proximal aneurysm, and those aneurysms, they tend to be a bifurcation point, then we would treat those aneurysms, we would target the rupture site. So if it's the AVM, treat the AVM first, but we would deal with those aneurysms like we deal with the berry aneurysms not associated with AVMs. The cases that we presented, the aneurysms that I think you can leave alone and the weight are of course the more distal ones, but the proximal ones, of course, there are considerations related to size, morphology, like same consideration that we would use for aneurysms in other locations. For example, in the case that we discussed, I would not have left the anterior communicating artery aneurysm alone. And I think that it was actually reasonable if you were not to treat in the same setting of the AVM, because it was in completely separate territory. I think that the strategy that was followed in this case was perfect strategy. Do safe coiling, and actually we didn't show the follow-up, but after a year, that anterior communicating artery aneurysm was stable. There was no increased recanalization because I think the coiling probably protected the patient against the risk of rupture, and then there was the relative decrease in the hemodynamic stress related to the fact that we treated the AVM, and therefore the flow across the ACAM also was reduced. But for proximal flow-related aneurysm, I would say we would follow the same strategy that we would follow for a bifurcation aneurysms or aneurysm along the circle of Willis that are not related to arteriovenous malformations.
Thanks.
Professor Lanzino, you didn't show us the change of the ACAM aneurysm after 10 months. How about, is it stable or?
It's stable. It
Okay.
looks exactly the same. And I think a part of it is because also there was decreased flow across that ACAM. So just coiling alone of a large aneurysm so far, of course, we will continue to follow over the years, but so far was good enough to provide, I think, protection, and at the same time, in that particular case, as we discussed, avoiding additional endovascular strategy precluded this patient from being on dual interplatelet therapy and allowed us to do surgery safely. So the second case, I apologize for those that were at the webinar that we had for the Educational Academy 2 days ago, but there was a lot of discussion about this case that I thought some of the audience is different. I thought it was reasonable to bring it back again. So this is a case of the young lady who presents with progressive sensory symptoms and imbalance. And we discussed the fact that, we like to be as schematic, but the problem with cavernous malformations in the brainstem is that, like in this case, this is not a pontine cavernous malformation, but this is a pontomesencephalic cavernous malformation. So cavernous malformations, they tend to span more than one compartment of the brainstem. So that's one issue. The other issue is that not only they tend to span different compartments, but within the cavernous malformation itself, you have different component. Like in this case, the pontine component, you can see on T2, there is an established and fairly thick hemosiderin ring around what I would consider the active portion of the cavernous malformation. Why that is important? Well, that is important because it tells me that that part will be the most difficult portion of the cavernous malformation because it's well established, has been there for a long time, and it's fairly adherent to the surrounding hemosiderin stained parenchyma. And then there is a different component, which is the mesencephalic component that we see on the right side of the screen. In that part, there is a fairly large hemorrhagic component that I know once I enter that bubble, that portion, the blood will come under pressure, and I'm able to debulk internally that part. But then in the mesencephalic component, there is the most medial part that is, again, what I would call or consider the more established portion of the cavernous malformation, that is more adherent to the medial part of the brainstem. And I know that in this patient that does not have visual symptoms, especially in the upper portion of the medial part of the mesencephalic part of the cavernous malformation, that part will be close or even adherent to the cranial, to the oculomotor nuclei. So this is again to bring home the concept that when we think about a surgical approach to an AVM like this, and of course, I'm not proposing superiority of one approach over the other, but one could say this one you could potentially go subtemporal. I think it's a little bit posterior. Number two, you see that the subtemporal approach gives you a bias that is directed from below up. You could go through the middle cerebellar peduncle, but again, the most medial and the inferior part of this cavernous malformation are the most difficult ones. It doesn't really come to the surface of the fourth ventricle, and we discussed, and we can discuss later on that I think if you can stay away from the floor of the fourth ventricle, unless the cavernous malformation, there is a true exophytic component going through the floor, I think it's better. So I contend that in this particular case, it would be nice to have an approach that gives you a preferential view of the more inferior and the medial portion, and the hemorrhagic portion provides you an entry point. So if you have a view from above, from top down, then I think that it would be easier to deal with the inferior part of these cavernous malformations and the most medial part that are, in my view, the most difficult part of the cavernous malformation. And that's why in this particular case, we went through a posterior, and it's a interpalatal posterior tentorial approach that takes you right down to the immediately below the inferior colliculus. And in this particular case, provided us. So you can see here, the patient is positioned in the lateral or park bench position. The side of the pathology is down, so you take advantage of gravity. When you start, as we know, you get the impression everything is tight, but as soon as you gain access to cerebrospinal fluid systems, the brain comes down. Here is identification of the straight sinus. Cutting the tentorium, it's always a little bit challenging, but once you identify you get a beautiful view of the dorsal portion of the midbrain, and you can see the classical steps, enter the cavernous malformation, decompress the liquefied hemorrhagic portion, and then identify the thymocytarine stained brain parenchyma. And then again, you see now you have a preferential view to the most inferior and medial portions of the cavernous malformation that, as you can see, it's more established. It's very adherent to the surrounding brain. And here is where you have to work very carefully not to traumatize that parenchyma too much, but at the same time, being very careful not to leave any residual behind. So I thought since there was a lot of discussion about this case, here is the pre on the left and the post-op on the right. And this patient did actually very well. She long term, she still has some mild residual sensory loss, but otherwise she has no other deficit. I warn you that what I've learned with this approach is that once you displace midline, because there is a lot of cerebrospinal fluid that is drained, and as the brain, as you could see, then the space opens up. But as you displace, as you manipulate mesial structures in the immediate postoperative phase, these patients can have, like this patient had some visual field issues, but they resolve as long as there is no damage to the visual cortex, which of course, I mean, in this case, we went anterior to the primary visual cortex. It was most of a posterior interparietal approach, but I've noted that on the dominant hemisphere, when you displace the mesial structures, there is in the immediate postoperative period, the patients can have some degree of confusion, which again, provided there is no permanent damage and no excessive manipulation of the mesial structures, because of the approach, they tend to recover. So this is another case, and I'm indebted to Johan Alexander, one of our students, and Dr. Agosti. Again, a similar case. This patient presented that definite one bleed, maybe one bleed, another bleed the year before, but he had presented with some ipsilateral weakness and sensory symptoms, and you can see here the same dilemma. This is it's a pontine cavernous malformation that extends superiorly toward the midbrain, doesn't really come to the floor of the fourth ventricle. So again, in this case, to devise an approach that gives you a superior to inferior view of the cavernous malformation, and once you can identify an entry point in the through the subcollicular area, I felt that this would give us a better access to this cavernous malformation. And so this is, of course, there are another approach would be to go through the middle cerebellar peduncle through a retrosigmoid or petrosal approach, but in this case, we decided to go with the posterior interparietal transtentorial. Again, this patient was positioned in a modified park bench with the side of the approach down. We were monitoring, of course, somatosensory motor evoked and the brainstem evoked potentials. Again, gaining access to the interhemispheric fissure. At first, doesn't look like there is enough space. Then the space opens up. The straight sinus. Of course, you can, based on anatomical landmarks, in some patients, it's fairly easy to identify because you can see. In other patients, it's not quite as immediately evident, but so I prefer to have the confirmation of the intraoperative Doppler and then cutting the tentorial parallel to the direction of the straight sinus in order to gain that superior approach to the cerebellar mesencephalic fissure. Here you can see opening the posterior part of the collicular system, and here you can see we are looking from above at the dorsum of the midbrain. You can see the fourth nerve, so we follow the fourth nerve laterally, so we are in the infratrochlear part, and we look for an area of discoloration or to identify the area where the cavernous malformation comes closest to the surface. We use neuronavigation in this situation. You can see cavernous malformation. It's always deeper than the MRI would suggest, but once we get there, we found splitting the fibers in the direction, the tracks in the direction of the fibers to minimize damage. And then if again so here the main point is the approach, and you can see how you have that posterior view from top down, and this is top is here, this is the inferior part, and you can see we go underneath the trochlear nerve, open really widely as much as possible that cerebellomesencephalic fissure to cut the arachnoid so that we can mobilize the cerebellum inferiorly, and then identify and find your entry point and the usual steps for removal of the cavernous malformation. Here is the post-op in this patient. I think here again, I like to show how you always think that the lesion might go through the floor of the fourth ventricle, but you can see here with this approach, you are able to preserve that thin layer of fourth ventricle that it's almost always there, except in those true exophytic lesions. So this patient post-op did have some worsening of his ipsilateral sensory symptoms and loss of position, and was discharged to rehab and discharged from rehab home after a period of 3 weeks. Any comments about this? Or I think there was a lot of discussion when we originally presented these cases about you go through the floor of the fourth ventricle when you do it. I think it's mostly related to personal preferences, but over the years I learned to really respect the floor of the fourth ventricle, and particularly because of the manipulation of the medial longitudinal fasciculus, and patients can develop very tedious, mostly extraocular motility problems. And I say that when I look at the brainstem surgery for cavernous malformations, I noticed that the long-term morbidity is mostly related to cranial nerve and primarily extraocular motility, coordination issues, and dizziness, rather than major sensory or motor dysfunction, at least the patients I have operated.
I have a question, Dr. Lanzino. For generally, complex operations and for rare conditions, there's a strong case, I guess, that expertise and caseload result in better outcomes, right? And this is the sort of case that demonstrates that you wouldn't want just anybody embarking upon this operation. But So where does that leave people who are coming into the game now? Who, you know, I'm speaking partly for myself. You know, young neurosurgeons who are growing and wanting to expand their skill set. How do you, in this day and age, embark upon an operation of this magnitude when you're just starting, or are we too late? You know, have we missed the boat, and should we just be passing on these cases to somebody who's done them before?
Yeah, no, that's that's all a great question, and anyone who does this type of surgery, also we know that we ourselves we go through our own learning curve, and we're still in that phase. We always like, as I said, we always like schematics. We always like to talk about cavernous malformations like they are all the same lesions. The truth is that there are different shades of gray, and I wouldn't say each one is different than the next, but there are a lot of nuances, even though the pathology might look the same under the microscope. I would say, the first thing I would recommend to watch Neurosurgical TV, and I'm serious in the sense that. Yeah, it's true what you said, but at the same time, if I look at my training, if I look, Professor Goel and I, we were together in Pittsburgh for 9 months in 1990, 31 years ago exactly. I went in October, and that was the only way to learn in those days. You just take, if you have the time and, it takes money, and you travel. Nowadays, I try as much as possible to join many of these webinars, because I learn constantly from colleagues around the world. So there are, I think now there are unique opportunities where the learning curve can be shortened. The other issue, I think it's a bigger issue, is that when we talk about problems like this, we like to show this. Of course, we show edited videos, we show our best cases, but we don't really like to talk, okay, once you get there, how do you actually remove the cavernous malformations? When it gets stuck, what kind, we tend, we should do, I think, a better job at teaching, all the different and true aspects. But at the same time, the learning opportunities that are available today, and they are worldwide. I mean, you see Neurosurgical TV, what goes on around the world, and the quality of the operations, the approach, the videos, it's in different parts of the world that only 20 years ago that was not possible. So yes, and I think from a organizational, organized neurosurgery point of view, there should be a better coordinated effort to make sure that problems like this are not diluted because each one of us does 3 a year, but as much as possible, they are concentrated. Now, in some places, some countries, it's a little bit easier. In other countries where there are different logistical problems or socioeconomical issues, it's more difficult. But I think that, yes, it's for young trainees, the learning opportunities that are available today, just without leaving your house, where I think that adequately utilized, they can help in shortening the learning curve.
Thanks, that's great. Does anybody else have any questions about this case?
Yes, Lanzino, I think this is a very wise choice to use this approach. Actually, before the surgical plan, actually this use this approach. I think the blind corner of the lesion is least. So if you use the fourth ventricle, actually sometimes some part of the lesion is quite difficult to remove through the fourth ventricle, like the first case. Yeah.
Yeah, and actually, as I was preparing for the first case, there is a good video from Professor Shuben group that I think was in operative neurosurgery that detailed nicely also some of the issues of this this approach. We have time. I think we can do another case, and again, the discussion here, I think it's on again on the approach is not so much the pathology, but this 37-year-old presented with 2 seizures and had this this hemorrhagic lesion and a fairly significant amount of edema. And in this case, is a supratentorial cavernous malformation, so it's not that important. But you know, the timing of surgery, this is a cavernous malformation. You can see that these cavernous malformations, especially when there is an important acute hemorrhagic component, they are often associated with edema. And if you operate in the immediate acute phase, the surrounding brain, it's very soft and almost liquefied, and it's more prone to damage, as opposed to waiting 2 or 3 weeks for that edema to improve, the hemorrhagic portion of the blood to become more liquefied, and also to allow for some degree of reaction of the surrounding brain and early gliotic changes that facilitate separation of the cavernous malformation from the surrounding brain. So that's why many of the reasons why, if possible, we don't like to operate in the immediate phase. And of course, there are, like anything else, there are exceptions. It's not a rule. Now, in this case, I will show you the MRI, but the main issue is going to be, do you go from the same side or you consider going from the contralateral side? In this patient, an angiogram was done because in the acute phase, as you know, on the MRI, it's never perfectly clear whether it could be a cavernous malformation or something else. But the angiogram here was helpful because it told us, you know, in this case, it tells us the location and position of bridging veins that are important in the approach. And I think here what's most useful is the coronal MRI, because it's, you know, you are very close to, if you are pretty much in eloquent area. So if you go from an ipsilateral approach, you can see that you can gain access to the most medial portion of the cavernous malformation, but this part can be, the most lateral part can be quite difficult. If you go from the contralateral side, the downside is that you have a lesion on one side and you put at risk the structures in the hemisphere on the other side. So you put at risk basically 2 territories. But the contralateral approach, it gives you, with the side of the pathology, you put the head parallel to the floor with the side of the pathology up. And basically, once you gain access to the interhemispheric fissure, as I will show here, you basically are looking right at the lesion. When you choose the contralateral transfalcine approach for sagittal, parasagittal lesion, so it's important that you have a little bit of room because your blind spot is going to be about 1 centimeter, is going to be up to here. You know, you have the superior sagittal sinus, and you cannot see immediately what's exactly again on the opposite side, because so you need that lesion to be at least 1 centimeters below, I think, at least what I found. Of course, with the cavernous malformation, it's more of it's more hemorrhagic, so you can try to tease out, but we'll see. I think the video will illustrate some. So here is what we did. We did decide to go contralateral transfalcine. The patient is lateral with the side of the pathology up. The head is slightly flexed superiorly, so like this, so that you can see, can look really, once the brain drops, you are looking right at the folks. We were close to primary motor and sensory cortex, and we monitored, and we knew we were going to work through 2 large veins. So again, here we gain access to the interhemispheric fissure, and of course you have to be extremely careful because you don't want to damage or put any undue traction on the normal hemisphere. So here again, the neuronavigation, I think once we are looking at, we expose the folks, it's nice because it gives me the, before I start opening the folks, it gives me confirmation that I'm looking at the right trajectory. And then you can see, once again, the cavernous malformation, it's always deeper than you think, but you can see the hemosiderin discolored brain, very thin layer of brain. And then once working after you remove the folks, you are really looking at the mesial portion of the lesion, and then going around. But again, even with this approach, there is a corner which is the blind corner, which is the most superior and lateral portion of the cavernous malformation. And you can see here, you can bring the endoscope, or we use a small dental mirror, and we were able to see that there was still a small residual right in the blind spot, and we were able to identify and remove it. So it's a nice approach because, of course, it gives you a preferential view to the medial portion of the lesion, so you don't have to manipulate the ipsilateral hemisphere. Again, you can see with the micro neurosurgery, you can work through a narrow corridor, but you have to pay a lot of attention to, not to put at risk to territory. Here you can see the pre and the post-op, and you can see the nice trajectory. And here is the post-op to show basically that primarily that the contralateral hemisphere on the flare. Here you see on the side of the pathology, you still see some of the residual edema, but more importantly, on the side that we went through, there is no flare signal. And you can see that we were right in the, motor, straddling motor sensory primary cortices. So I thought that this case was a nice representation again of how we use, we think about surgical trajectories, and I'm always have a lot of apprehension when I use this approach, because as I said, you put at risk two territories. So when you do it, you must be extra careful not to jeopardize particularly the normal hemisphere. So it's a lot of, at least on my part, a lot of anxiety, but with modern microsurgery and respecting all the principles and taking really the time to open and release those arachnoidal bands, tethering the mesial portion of the brain to the dura and the folks, and really work carefully. And even when you see that you get the impression that there might not be enough room in between two bridging veins, usually by releasing the arachnoid, you can skeletonize those veins and gain enough room. But also as you work and under the microscope, we tend to be focused on the area we are working. Always be cognizant of those veins, because you might spare them, but then if you put too much traction or you put those veins under tension for too long, they might thrombose. So a lot, of course, of pitfalls that are fairly familiar to all of you, but I find it's nice to discuss, and I'm like to hear different opinions. Again, some colleagues would have gone through the same side, and I think that that would be perfectly fine, except that I think you struggle a little bit more in having a more ideal trajectory.
Dr. Lanzino, we have a question in the chat, and it's come to us from the Czech Republic. Alice, who's asked the question, have you got access to a microphone? Do you want to put your question to Dr. Lanzino?
So, hi, Alice. Alice is a good friend of mine for many, many years. Yeah, opening the folks and cutting the tentorium, it's nice to be here and talk about, but it's really not that straightforward, especially when you're working in a very narrow space in between two bridging veins. I don't have any trick, except that I try to, put like there is a sharp, I think it's a rotor 9 instrument, and grab really a little bit of the outer layer of the dura to pull it toward you, as with an arachnoid knife, very, very carefully try to open the fork so that I don't transgress the contralateral arachnoid. The issue in doing that, as you will know, is that when you cutting and you are being very careful and you go slowly, you cut the outer layer that is on the side of your approach, and you end up into a venous plexus, because the tentorium and the folks are nothing but two layers of dura with the venous plexus in between. So once you are getting to that venous, and sometimes the venous plexus, as we all know, it's particularly, especially in the tentorium, can be quite exuberant, but usually you work very carefully. And once you make that first nick in the dura, across the full thickness of the dura, then you are able with the bipolar to coagulate across and extend your cut.
So we've got one more question in the chat here saying,
yeah,
you can see that, can you?
Yeah, it's as I said, I don't, that's why I wanted to present this case, because yes, you go from, in this particular case, from the dominant side. Now, I think you can do it for cavernous malformations, especially when there is a large hemorrhagic component. It's like working in the brainstem. You can remove the cavernous malformation through a very small incision, and so it becomes very, very important that you have the ideal trajectory. But again, it worked in this case, but I agree with the colleague says you go from the left side and you go right in the you are working right against the primary motor and sensory cortices. So yeah, it's as I said before, the downside is that you put two territories at risk, and it's a good counter argument for not doing the way I did it.
Hello, Professor.
Yes.
Harshad Parekh. Hi, Lanzino.
Hi. Yes.
You remember me? We talked
do.
many times.
I do. Yes, absolutely.
This is my question. I asked for the contralateral. Why? What made you to think go to contralateral? What I feel is that if you go from the same side, probably you may hit the lesion much faster than the contralateral side. And as you have rightly given an answer, both hemispheres get affected. And my worry is the veins more. If you by mistake damage a vein on the left side, we are in a trouble more than the going from the same side. And
I fully agree with all of your concerns, and as I said, that's why I put this case there to discuss all possible options. But you can make the counter argument really that if you go from the ipsilateral side, you are able to get to the lesion, but if you want to do it without it will not have been as simple to reach the most lateral and the superior portion of the lesion. But again, it's I agree with you. I'm not saying that the approach we did is necessarily the right one, because there were a lot of counter arguments, and we discussed this with my colleagues, and doing the surgery I was very, very very careful, extra careful, but very worried about all those issues.
If the lesion was on a left side, the similar mirror image, probably I would have gone from the right side.
Mm-hmm.
Because the right side being a non-dominant, maybe I will be more beneficial to go from the right to the left than rather than going from left to the right. Maybe this is my perception. I'm not contradicting your view.
No, I agree with you. Again, if I had the same case again, I would think very, very hard on the best way to do it. I am a little bit more, I used this contralateral approach. I trained with Dr. Spetzler, so I used this contralateral approach quite a few times.
Yeah.
But no, I absolutely, there are different ways to do it, and I'm not sure, of course, we cannot base our decision. We tend to base our decision on a single case, but we have to think, okay, if I do this 100 times, what are the risks and benefits? And I'm glad you brought it up, because I'm perfectly in agreement with you that an ipsilateral approach would have had some cons, but would have had also several pros in this particular case.
I agree. Dr. Spetzler goes in many times contralaterally. I've seen his videos, I've heard him, and he is a great favoritism for the left opposite side of the lesion.
Yeah, no, there is no question that it provides you with a better angle of view.
Correct.
The problem it's always, okay, what is the potential price? What are the risks?
Correct.
And there is no question that way you put two sides of risk.
Yeah. Excellent. I liked all cases of yours, and wonderful. As you are always great whenever you are giving presentations, and it is privileged to be part of the presentations.
Thank you. So
Lanzino,
pleasure
thanks.
to be here.
Yeah, thank you.
Hello, Professor. Hello.
Hi.
I'm Dr. Pawan. I'm a neurosurgeon in Nepal. And regarding your contralateral approach, it's actually one of my preferred approaches. I've used it a couple of times, but especially for tumors. I've used it for GBM, METs, and a meningioma. I think this is a very, very elegant approach, provided that you position the head appropriately. And so far, luckily, I haven't had any issues with any new deficits on the ipsilateral side from the corridor that we've used. And I think it's a very, very elegant approach. My issue with this approach is like, I'm always confused as to how high up should I cut the fox. That's always, every time I do it, I am always confused as to how high up should I go, because I'm always worried about injuring the cervical sinus while getting the cut up, going above. And regarding another thing about how to cut the fox, what I tend to do is I make a small window, then push a cottonoid behind the fox. That way it gives me protection while cutting the rest of the fox to make that proper window. And another question that I'd like to ask you is, I've like a couple of times, like in two of my cases, I cut the fox all the way down to the inferior sagittal side because it had to be done. And luckily, it made no difference. There is no new deficits while after cutting the inferior sagittal side. What do you think about that?
No, I think that the only time I would be very, very careful about that is that if you have a meningioma that is occluding the superior sagittal sinus. In those situations, then the sinus is bypassed. I've had patients where the bypass to the sinus was actually through diploic veins through the bone. And so in those situations, you have to be careful. But I agree with you, and having done also thousands of angiograms, the inferior sagittal sinus rarely seems to be, fairly developed. So I would say I agree with you that I don't think that the risk of major consequences there when you interrupt this inferior sagittal sinus, except in those situations where the inferior sagittal sinus might serve as an important collateral pathways, and those are usually cases where the superior sagittal sinus is involved. Another little trick that I have learned is that as you make your dura incision in the folds, then you can use the folds actually to protect the side of your approach. We can lift that fold so that your instruments are actually against the dura and not against the P. arachnoid.
Thank you.
Okay, well, I like to thank everybody for your participations and all the colleagues around the world, and John for coordinating this, Shuben and Dr. Takahashi for translating. Hello, Hugo.
Hello, how are you, Professor Lanzino?
Good.
Very good cases. So I completely agree with you. Respect the TV Neurosurgical that is giving us the opportunity that 20 or 30 years ago we didn't have. So respect to the cavernous brainstem, I think that this approach that you show us are surgeries for masters, for experienced brain surgeons, and think that at the level of brainstem, and in a very small space where neuronal nuclei are very close, vegetative, motor, sensitive fibers, there is no safe entry point. The safest point one is the one you have performed in the laboratory of anatomy and your own surgical procedures. So I think it's not surgery for all the brain surgeons, it's surgery for only few brain surgeons, for masters.
Yeah, and Ugo, the other thing to stress is that for cavernous malformations, I agree with you. Yes, entry zones. There are, if you consider the anatomy, and also what I pay a lot of attention is the symptoms, how the patient presented, how the symptoms evolved, more than the DTI on MRI. That provides me with the, with the cavernous malformation, we also use the fact that the cavernous malformation displaces and pushes the normal parenchyma aside, so often provides us with the hemorrhage a entry point. But I agree with all the points that that you made, that there is no safe entry zone, but at the same time, utilizing the corridors created by the cavernous malformations, the anatomical knowledge, the patient presenting symptoms that tells you which tracks are involved, and making your incisions parallel to the direction of the tracks and working in a narrow space allows us in many patients. But the other thing is that the morbidity is also of brainstem cavernous malformations. It's not negligible, from the surgery.
Thank you, Professor Lanzino.
Okay, very good. Thank you very much. Nick and you are easy to work with. And this is a great teaching concept. I wish I was a medical student again. Anyway, will we see you again in a month, Dr. Lanzino?
Yes, and actually, if Dr. Perez is available, he has very beautiful.
There are 4 prospective randomized
Oh,
trials.
I'm sorry. That's
of
not me.
I said, of course, all of us know the 1-year results were good. But
I'm sorry. Let me get that.
No, that's fine.
Okay, go ahead.
No, if Dr. Perez is available, the next time we can talk about spinal vascular malformations, and he has some beautiful dissections and also beautiful videos of injections where he can show how the vascularity from the arteries to the veins, and it would be nice to do something combined.
Of course, Professor Lanzino, will be an honor for me. Thank you so much.
That's great. Okay, thank you very much, everybody. We're going on to Victor's webcast on neuroanatomy in Spanish. And thanks again, Dr. Lanzino and Nick.
Thank you.
Thank you.
Thank you,
Thank you again, Lanzino.
Thank you.
Today, you know,
in
WeChat channel, we have
Thank you.
800 audience attend this webinar.
Wow.
Thank you again.
Great. Thank you. See you later.
Thank you.
Sure.
See you later. Thank
Bye.
you.